Bonjour à tous, je ne parle pas français très bien, donc je parle en anglais. My name is Brandon. I'm an assistant professor at Brown University. Prior to taking an appointment at Brown, I was a PhD student in Vancouver, Canada, where I worked on the evaluation of North America's first supervised injection facility, InSight. I'd like to use the evaluation of this facility today as an example of the role that scientists and the scientific community can play in shaping evidence-based drug policy in North America and elsewhere. So, as a Canadian moving to the US, I've enjoyed listening to a national public radio broadcast called This American Life. And while I was preparing for this presentation, they interviewed Alan Alda, who's made it his life work to teach scientists how to communicate more effectively with the public. He's also founded the Center for Communicating Science at Stony Brook University, which has this charge at the core of its mission. Scientists have a responsibility to share the meaning and implications of their work. And I argue that not only do we have a responsibility to share the meaning and implications of our work, but we have a responsibility to do this effectively to positively influence evidence in drug policy, and that's what I want to talk about today. So I'd like to discuss what I see are 4 barriers, there's likely many more, to the adoption of evidence in drug policy. The first is that publishing in peer-reviewed journals is not sufficient to achieve these goals. And I'll discuss some innovative knowledge translation tools that the InSight research team has used effectively to ensure that our evidence is disseminated and adopted effectively. Secondly, to use evidence in drug policy, we first must learn how to communicate it effectively to the public and to policymakers. And unfortunately, much of our science is communicated in a misleading or in an exaggerated, perhaps harmful manner. So I want to provide some examples of that. Furthermore, we see in the media, politicians and other groups, the perpetuation of what are harmful stereotypes and often untrue doctrines of drug use and addiction. And I'd like to turn the mirror on us this morning and think about how scientists may be doing this inadvertently or unconsciously in our communication, in our own writing. And finally, in the context of the supervised injection facility in Vancouver, I'll discuss the politicization of science by government and other special interest groups and what scientists can do to mitigate this very harmful process. So the conceptual model that I'd like to use today and that the InSight evaluation team uses is that of knowledge translation, which was defined by the Canadian Institutes of Health Research in 2000 to refer to a cycle that starts at knowledge creation, moving to transfer and dissemination to stakeholders in the community and in the public. We use knowledge translation to help bridge the gap, right, between what is known and what is done in practice, understanding that there's often a large gap between these two things. So for example, some knowledge translation activities that we've used in the context of the supervised injection site in Vancouver are things like media engagement with both print and broadcast media to disseminate our scientific findings widely. We've synthesized what is a large body of scientific evidence into layperson plain language reports that again can be adopted by the public, by policymakers, and implemented accordingly. We've presented many oral presentations, not only in academic conferences, but to politicians, journalists, community-based organizations, and so on. And we've used the internet and social media to disseminate our findings as broadly as we can, and I'll show an example of that later. So before getting to the evaluation of InSight, I just wanted to highlight a couple of examples from these 2 points that I wanted to make. The first is that our communication of our findings is often inadequate and potentially harmful to the communities whose health we're trying to improve. This is a quote from a press release published in a study recently in Nature Neuroscience, and I've pulled right from the press release here, looking into the frontal lobes of live mice at a cellular level, researchers found that after just one dose of cocaine, the rodents showed fast and robust growth of dendritic spines. Quote, "These drug-induced changes in the brain may explain how drug-related cues come to dominate decision-making in a human drug user," said researchers. So whether you believe or do not agree with the conclusion of these findings, these kind of headlines result. Cocaine rewires brain after single-use, study says, and at the bottom, using cocaine once is enough to rewire the brain and cause addiction, according to new research. So not only is this untrue, right, flagrantly untrue, and greatly exaggerating these findings, it's potentially harmful. And I don't think we should blame the media for these sorts of headlines. Their role is to sell papers and headlines. Our role as scientists is to ensure that our findings are communicated and represented accurately. And we've worked very closely with journalists and the media to ensure that this is the case in the context of the supervised injection site. And in my own work, I've found that journalists are often very willing to engage in a two-way form of communication to help them understand the study results better and avoid these sorts of flagrant claims, which influence the public's perception of drug use research and drug policy. I've seen this also in an example of my own work, and how scientists themselves can actually commit these sorts of errors and communication flaws. This is a study I published in 2000, which was a systematic review of health outcomes associated with methamphetamine use among young people. We screened over 2,000 abstracts and ended up identifying nearly 50 articles that met our inclusion criteria. We assessed the quality of these studies and then ranked them according to the ICD classification system to understand the strength of evidence between methamphetamine use and various harms among young people aged under 24 years of age. And before I get to our findings, I'd like to show you how the paper has been cited in the literature. A strong, and I quote, "a strong association between meth use and increased risk of HIV has been substantiated by multiple studies," cite. Another reference, "another common result of methamphetamine use is what is known as meth mouth. This is a serious oral issue which involves extreme decay and loss of teeth," cite. In fact, what we found in our study and what we stated directly in the paper is quite the opposite. However, we failed to observe a strong evidence base for previous cited and methamphetamine-related harms, including an increased risk of HIV, STI infection, and onset of dental diseases such as tooth decay among methamphetamine users. So, not to say that these relationships don't actually exist, but the evidence to support them is weak or non-existent, often reliant on anecdotal reports or case series in the context of dental diseases. So why is this study then used or referenced in a complete opposite manner to what we found? And I think what's going on here is that we as scientists live and do research in a society that universally views drug use as harmful. And so it's difficult to operate outside of that dogma and context. And we end up committing a kind of confirmation bias where we interpret scientific findings that affirm our prior held beliefs. And I think we need to do a lot more research to understand the magnitude of this problem in the literature and ways we could ameliorate it. So I wanted to move now to the evaluation of the supervised injection site in Vancouver, InSite. This is a lovely photo taken by my colleague MJ of the front door of the facility. It's located in the downtown east side neighborhood of Vancouver, where there are approximately 5,000 injection drug users residing. The facility was opened in September 2003 due to a public health crisis of fatal overdose in Vancouver. We were observing rates up to 40-50 per 100,000 person years, which is at least 5 times that observed in the United States and other cities in Canada during the early and mid-1990s. Concurrently, we were observing a twin epidemic of HIV incidents in 1996, We published a study showing one of the highest incidents of HIV observed in North America to date. Due often to the environment in which drugs were being injecting in the downtown east side, you see here extremely unhygienic environments which lead to a greatly increased risk of HIV, hepatitis C, and other infections. So in 2003, Insight was established with an exemption from Canada's federal drug laws with the context that it be evaluated scientifically. The goals of Insight are threefold. The first is to reduce public injection drug use and the unsafe disposal of syringes in public spaces. And the evidence to support that objective was shown in the previous session. The second objective is a public health objective, and that is to reduce overdose and infectious disease risk. And I'll show you some of the results supporting that objective. And the final objective was to improve access to healthcare services among people who inject drugs. Even in a context such as Canada, which has a universal healthcare system, drug users continue to experience many barriers to achieving appropriate healthcare and even stigma and discrimination while doing so. So this is what Insight looks like on the inside. It consists of 12 injecting booths. Individuals come into the facility, they register with a username or an anonymous handle, and then enter into this room, which is the injecting room, where they inject pre-obtained illicit drugs under the supervision of nurses and other health professionals. In the event of an overdose or some other adverse event, nurses intervene and provide naloxone or another appropriate intervention modality. Following injecting, the client moves into another room called the chill-out room, where there's coffee and other services, peer support services, and also addiction counselors who can speak with individuals and even help them get them enrolled in detox and addiction treatment services, which are co-located in the facility. There's a detox on the second floor of Insight and a substance abuse treatment center on the third floor. And we've shown in a study published in the New England Journal of Medicine showing that use of the facility increases uptake of these services by 33%. So the evaluation now has gone on for over 5 years. We've published over 30 peer-reviewed studies in various journals. I won't go through all of these for you today, obviously, but I will highlight a couple that I've been involved in. I just wanted to show you some statistics here from the operation. We recently celebrated our 10-year anniversary, where over 2 million visits have been recorded from over 12,000 unique individuals. An average of 1,000 people visit the facility per day. That operates at capacity, and there are approximately 500 overdose events annually. And the most important thing to keep in mind here, if you take anything from my talk, is that there has been no deaths in the facility to date. So I'll just show you one finding that I led and was published subsequently in The Lancet in 2011, which sought to examine the effect of opening Insight on overdose mortality in the community. This was a population-based retrospective before-after study. We used data from the British Columbia Coroner's Office and examined all deaths that were deemed attributable to illicit drug overdose in a 5-year period. Note that Insight opened in September 2003. I then geocoded all of the deaths in ArcGIS and used data from Statistics Canada to calculate block-level fatal overdose rates and compared these rates pre- and post-Insight's opening, both within 500 meters of the facility, which is where the vast majority of clients live, and as a quasi-control, all other city blocks in Vancouver. So these are the main results now. This map shows you the location of every fatal overdose event in 5 years in the city of Vancouver. We used the 6-digit postal code, which was recorded by coroners or investigators. And in Canada, these refer to buildings or one sides of city blocks. So fairly good resolution, which gives you the information on the location of the overdose event itself. You can see here a clustering of fatal overdose deaths in the downtown east side, of which the SIF is located in the middle. When we zoom in on that area, I present here the block-by-block fatal overdose rates in the immediate vicinity of the facility itself, which is shown in red. Prior to its opening, which is shown on your left, we observed a rate of 254 per 100,000 person years, an extraordinarily high rate of fatal overdose in that neighborhood. In the period following Insight's opening, that dropped to 165 per 100,000 person years, shown graphically here. That works out to a percent reduction of 35%. Note that in city blocks in the rest of Vancouver, that reduction was non-significant and was only 9%. So to help disseminate these findings and others, as I mentioned, we've published plain language reports in both official language, English and en français, that summarizes the findings from our evaluation and are available on our website, in addition to a description of the methodology of the evaluation and also a summary of our findings. We've, as I mentioned, engaged the media exhaustively, really, to disseminate our findings. These are some articles from my study that was published in 11. We've held media events in the facility itself with community-based organizations, the operators of Insight, and drug users themselves. So finally, we have this large body of evidence, but as some of you may know, there has been opposition, and it's not without controversy. Primarily, this site has been opposed by the federal government of Canada, run by the Conservative Party. And I'd like to discuss, just in closing, how this facility has been politicized. They've been against this facility and have attempted to close it since coming to power in 2006, after the facility opened. And so far, thankfully, have been unsuccessful. And I really do think that's been in part because of not only the evidence we've provided, but also the ways in which we've communicated it and influenced public opinion, to the point where we have commentaries in local newspapers advocating for the use of science as opposed to ideology. The evidence, the government, I should say, actually took the facility to court, which went all the way to the Supreme Court of Canada, who in 2011 ruled to keep the facility open in perpetuity. And they cited the evidence as well. Insight has been proven to save lives with no discernible negative impact on the public safety and health objective of Canadians. And we were very pleased with that ruling. And are happy to see Insight continuing to be open today. So with that, I'd like to close and acknowledge, of course, the participants of our studies, in particular the clients of Insight, the operators of this wonderful facility, my research collaborators, and in particular, my mentor and PhD supervisor, Thomas Kerr. Thank you very much.